We have a special guest from GeneDx to talk about genetic diagnostics. I'm sure you all remember when you got the nice report that said all the jumble of letters and numbers. So please welcome Mary to the stage from GeneDx.
Hi, everyone. I have met a lot of you today one-on-one, which has been amazing. I do have to sort of share that I spent a lot of my career in clinic seeing patients, but it's been probably 5 or 7 years since I've been patient facing. And honestly, seeing you all today has just like really brought me back to why I do what I do. And I think sometimes as you get older, it's easy to kind of lose touch with like I don't know, just what motivates you and what grounds you. And so I want to thank you all for being here and for those of you that came by to share your story with me. It just really made a huge impact. And you guys are very inspirational. And I just wanted you to know that. So it's been an amazing day for me to be here. So thanks. So those of you that have met with me, you're probably going to hear some of the things that I talked about with you one-on-one today. But basically, I'm going to try to just really quickly in 20 minutes go through some basics about genetics and genomics, how we do different types of tests, why we test, and then the types of results that can come back. I am going to try to go fairly quickly just to get through, and then we'll leave plenty of time for Q&A. We're running ahead of time, which is great. So, um, okay, perfect. So the first thing I want to talk about is just genomic sequencing and just some basics about genes and chromosomes and DNA. So, you've heard the term genes, and essentially what I always say is that genes are instructions that tell our body how to grow and develop. And so the genes essentially code for a protein. And as long as the genes are correct, they're going to code for the right protein, and that protein is going to work the way it's supposed to in the body. And we have lots of genes in our genome. So the genome is the entire set of our genes. We have about 20,000 genes in there. And we know that when there are variations, or you might hear them called variants, you might hear them called mutations. When those are in a gene, they can cause the gene either to not work the way it should. And then obviously maybe it makes a protein, but the protein doesn't work well. Maybe it doesn't make a protein at all. And so those changes in the gene, that's how they impact the body, is by kind of adjusting the way that those proteins are. But what's interesting is, and I've said this to some of you today, is I think some people think genetic testing is so easy, like you do it and there's either a change or there's not a change. And it's actually not nearly that simple. So we have changes all over our genes, right? That's why we all look differently. Some changes are problematic and they're associated with a disorder or clinical symptoms. Other changes are completely benign, meaning that they're just things that make us different as human beings and they have no impact on disease risk, or they don't give us a specific disorder or give us any symptoms. And so that's what's tough about genetic testing, is that not only do we have to look through the DNA and identify these changes, but then we have to make a call on whether that change is problematic or not. And so we're going to kind of come back to that through this entire presentation. But again, just kind of emphasizing that like we all have these variations, and a lot of times they are completely benign and they don't make any difference at all. Again, a variant is a change in a gene that causes the gene not to work the way that it should, and then that affects the protein's ability to go do the work in the body that it needs to. And you might hear the term pathogenic variant, and that basically means that it is a problematic variant and there is a result because of that change in the gene. So when we think, and I will say, like, since we have plenty of time, I can take questions as we go along too, if that's okay. I know sometimes it's easier to ask your question when you're thinking about it, so feel free to raise your hand if you do have something. So then when we think about the human genome, if you see that diagram, we essentially have like sections of our gene that are called exons. And the exons are the things that actually make the proteins. And funny enough, it's only 1 to 2% of our genome that is exons. So most of the genome actually is not serving to make proteins. But what is also very interesting is that most of the variants that we know that are associated with disease are in that 1 to 2% of the human genome. So they're usually in the exons. We have introns that kind of split up the exons, and these basically kind of regulate the way that proteins are made. And that's about 24% of the human genome. So when you hear the term exome testing, you are getting testing of all your exons. When you hear the word genome testing, you're getting testing of the exons and the introns and the other non-coding DNA. So when you see that picture of the orange there, our whole genome is the orange, and then it's really just a small slice that are the exons. But that is most often where we see the variants that cause disease. So that's why often we start with exome testing, because where are we most likely to find variants? That's where we're most likely to find them. But again, it's a small part of the genome. We do know that there are about 20,000 genes in the exome. What's interesting is only about a quarter of those we know they are related to disease. So 3/4 of the genes, or 15,000 of them, we don't know what they're associated with, and that's why the more we test, the more we learn. And so, some of you may have heard of like a gene of uncertain significance, and that means sometimes we find a variant in a gene that we know is problematic, but we actually don't know what the gene really does. And so we can't say it's a problem because we're not sure what that gene is associated with. But in 5,000 genes, we do know they're associated with a specific disease. And if there's a problematic variant, we can give someone a diagnosis as to what disease they have. So again, usually we start with the exome because that's the most common place to find them. And then again, I think we've talked about this with most of you today. Usually the pathogenic variants that we find in the exome are de novo, meaning they're brand new. They haven't been passed on from mom or dad. And again, this will be repetitive for some of you, but essentially how it happens is there's this, the merging of the egg and the sperm, and there's all this genetic stuff that's happening with them merging, and there can be a mistake that happens, just like a switch, and it changes a letter in that DNA, and then that one cell starts to propagate and become more cells, eventually a baby, and then all the cells in the body have that specific variant. It is nothing anyone did. It has nothing to do with the mom's age, the dad's age, what the mom eats or drinks, what the dad eats or drinks, whether someone yelled at the mom last night. It has nothing to do with any of that. And so that's something I always want to get across to people too, because I think it's hard to be parents and feel like you're responsible for something. But this is nothing that anyone can control. It is completely a sporadic event in the majority of cases that just happens. And then it kind of goes on to, again, affect all the cells in the body. So just kind of another analogy. So if we kind of think of DNA as like our entire cookbook, right? Or our exome or our genome. So basically that is like this cookbook that holds all of these recipes to make all of these things, right? Chromosomes are essentially the packages that hold the DNA. And so those are kind of like individual chapters. And then the genes themselves are like the individual recipes. So the chromosomes would be like appetizers, meats, vegetables, desserts. And then the genes would be those individual recipes. And we're going to talk next about the different types of tests and what they look at. But again, exome and genome sequencing are going to look at the entire cookbook, whereas a test called chromosomal microarray, or CMA, is going to look more at the chromosomes and the structure of the chromosomes. And then we have single gene tests and multi-gene panels that are going to look at the individual recipes. So moving on from that into the testing strategies. So again, just kind of touched on this, but you know, quite a while ago, all we had was chromosomal microarray. And so you will hear this test done. And it is an important test because it can find things that some of these more advanced technologies will miss. But basically that's looking for extra or missing pieces of chromosomes, which are also called copy number variants or CNVs. But you can see that the diagnostic yield for CMA, which basically means how often do we find something when we use CMA, is 10 to 20%. So 10 to 20% of the time when we test with CMA, we find something. We can also do a multi-gene panel where we basically choose different genes that are related to something. So for example, there are autism panels. So panels of genes that we think are related to autism, and we can do a panel test to look at those specific kind of recipes, right? And then we get into exome and genome. So prior to 2012, 2013, multi-gene panels were really the thing to do. But then exome kind of started coming up, and we realized that actually that's going to really identify a lot more patients. So we find variants in the exome in 40% of cases. Similar with genome, maybe a little bit higher because it can find things that are outside of the exons. But the thing that you have to remember is that we are learning more and more every month as we test more people. And so that's kind of the problem with multi-gene panels is you have to pick a panel and choose to test it. Well, what if 6 months from now, there's 5 more genes that we know of that seem to be associated with autism? Well, you had your panel. Now, if you want to know if you have those 5 genes, you have to have another test, right? Versus with exome or genome, those are tests where we sequence everything and we have all the information. And then if we have a new discovery, we can go back to the data that we have from that exome or genome and interpret it. So that's why a lot of people are moving to exome and genome, is just because it is so versatile and it allows us to basically adjust our approach as we learn about new genes and new variants. Exome definitely finds things that other tests will miss. So finds twice as many things as chromosomal microarray. Again, CMA sometimes will find things that exome or genome might miss, so it is valuable. Mostly with exome. Genome pretty much finds everything on its own, but exome and CMA can be nice to use together. And again, genetic panels just can miss a lot of things. If you look at all the patients who were diagnosed with something by an exome test, 1 in 4 of them would have been missed if the doctor had ordered a panel on them, because there's just so many genes that aren't included on those panels. And then, like I mentioned, we have this thing called reanalysis. And not just GeneDx does this, all the labs do this, but and they may have different policies, but if you were tested a year or 2 ago and you didn't get an answer, you can have your doctor call in and say, hey, can I get a reanalysis, where they can go back to the data and see if there's anything new in it that they need to report. The other thing that I've talked to some of you about today too is trio testing. So the best way to actually do exome and genome is through a trio, meaning that we test the child who's affected as well as the parents. And the reason for that is that like I said, these problematic variants are typically de novo, meaning new in the child. And so if we test the parents and we know they don't have that variant, that's more suspicious to us, versus if we have a parent who's 35 years old and healthy and has a variant, you're like, well, that variant probably isn't associated with this condition, right? Because the parent is living and healthy and doesn't have it. So it actually really helps us in interpreting the data to have that trio. And it's not always possible to get the samples from mom and dad, but when we can, we like to. And so again, a trio is twice as likely to find a genetic diagnosis. We get fewer of these uncertain results than we do from panels, and then we get a higher diagnostic yield. So we find things more often compared to singleton, which is just testing the child, or duo, which is testing one of the parents and the child. So why test? So because professional organizations and really smart doctors say that we should, right? And interestingly, this slide needs to be updated because just about 2 weeks ago, the American Academy of Pediatrics came out with guidelines saying that genome or exome and CMA should be first line for kids with developmental delay and intellectual disability. So there's more and more guidelines coming out saying that these types of genetic tests, exome, genome, are important to consider for different types of symptoms that we're seeing that are listed on the slide. We also know that often genetic diagnosis can lead to tailoring patient care. So these are all related to seizures, but what we know is that depending on the variant in the gene, there are different ways to treat seizures. Sometimes it's just a diet, a ketogenic diet that can help. Sometimes it's a supplement or a vitamin. Sometimes there's a medication that if we give it to certain people with seizures, it's going to make them worse. And if we give it to other people with seizures, it's going to make them better. And we can tell what it's going to do based on that gene variant. And so it really does help us to tailor care and prescribe the right medication. And then even beyond that, this is with autism because we don't necessarily have that same type of kind of like treatment guidelines for autism, but we have heard from families. This is so helpful. It helps me to connect with other families that are going through what I'm going through. It gives me a name for this thing that I've been dealing with and trying to find an answer for years. It helps me to know what to expect. I can connect with kids that are older than mine, and I can learn about what their path was like. So even when there's not a specific treatment, there's a lot of things, a lot of benefits that can come from having a diagnosis. It's not to say it's easy, and that's what I think we want to be careful too. Like, it's not like, oh, yeah, I have this diagnosis and now everything is great. It's not. It's hard. It's hard either way. But I do hear from families sometimes that they are grateful to have this diagnosis because it does open a lot of doors for them. So again, lots of guidelines for when to consider exome or genome. This is a really busy slide, but, just kind of saying that, there are a lot of clinical symptoms out there that people should consider genetic testing if they haven't had it. And I know most people in this room have. So, and then just to touch on insurance coverage, I don't want to spend a ton of time on this, but insurance does cover exome and genome. Mostly exome is covered, but genome is actually really picking up. You can see here whether it's commercial plans or Medicaid, these tests are covered. And when you look even at Medicaid coverage nationwide, 33 states have Medicaid coverage for exome and or genome sequencing in the outpatient setting. So again, not to go into a whole lot of detail, and also in the NICU. So in the inpatient setting, rapid genome sequencing is covered by a lot of states. For Medicaid, we at GeneDx, as well as lots of other labs, are working on making more of these states the color that we want them to be. But it is something that's covered well by insurance. Most labs that you work with can check your insurance benefits or have some type of like safety net to help you understand how much you might have to pay out of pocket. But I think, I've heard some people say today, like, oh, my doctor told me it was going to cost all this money. And I mean, unfortunately, I think there are the doctors that are kind of not that don't specialize in this. They may have that misconception that this is going to cost people a lot of money out of pocket. But I had so many people tell me today, like, I paid nothing out of pocket, or, I had to pay my deductible, but then it was covered. So I think that's something to make sure people understand, is that it is often covered. And then, the diagnostic odyssey, that's a charged term lately. I think some people like it, some people hate it. Some people feel like it sounds like it's way too much fun. And I know what you guys go through is not fun. But when you look at, these stepwise protocols of doing different types of testing, they take years. And especially when it's hard to get in to see specialists and you have to wait to get in to see a specialist, and then that adds to it. Exome and genome first is really the fastest way to get an answer. And a lot of these professional organizations are jumping on board with that, as well as payers. So last, let's just go through the types of results quickly. So, obviously many of you in this room have a positive test result, which means that there is a variant in the gene. It causes OCNDS, and you have a diagnosis. Sometimes we can do genetic testing and we find nothing, and that's a negative test. Now, it doesn't mean that the patient doesn't have a disorder. It just means that we don't know what it is yet. And we may want to do additional genetic testing, or we may want to, like I said, go back in a year or two to see if there's something new. And then, like I mentioned, sometimes there are these changes that we're like, well, we know it's different than what we would expect, but we don't have enough evidence to say definitively if it's problematic or not. So, usually, those we often treat as if they are negative or benign, because most of the time they are reclassified to be benign. But again, it'll kind of depend on the clinical history and what's going on in the family and all of that. And I'll talk a little bit more about that in the next slides. So for those of you that have had a positive test result, very, very important to have a copy of that test result. It is shocking how many doctors do not give their patients a copy of the test results, so you may need to ask for it. These are the things you want to pick out on your report. What is the gene? Obviously, I think you guys all know that, or you wouldn't be in this room. What is the variant? Because, like we've talked about today, as I've met with people, a gene is like a big long sentence, and there can be errors anywhere along it. And some people may have the same error as someone else, but some people may have a different error. And so we call that the variant, the type of variant. And that's going to be, you can see, I do have a pointer, right? Oh, no, I don't. Sorry. So you can see in that table below, there's the gene, there's the disease, there's the mode of inheritance, there's the variant name. So that's going to be important to know. You want to know what lab performed the test. You want to know what kind of test it was. So was it an exome? Was it a genome? Was it a panel? And often you want to know when it was performed, because if it was performed a long time ago and you didn't get an answer, you might want to consider having the test redone. But again, in the case of a positive test result, these are just all important things to know and to make sure that you have on hand and can share with other providers that might be taking care of you and your child. So again, why is this important to know these things? Because you can find gene-specific groups like this one, because you can get support from other umbrella groups like Global Genes, NORD. You can find communities, you can find podcasts, and then, you can grow your community, right? So that's the point, is like getting this community together and growing it. And so really important to think about that too. And then that positive result will allow you to connect with certain clinical trials. You can read about it in the medical literature. You can find social media groups that are specific to it. So those are all the things that positive results can unlock. Like I mentioned, we can also have an uncertain result, but it's equally important to know all of the same things here. What gene was it in? What was the variant? Again, important to know what lab did the test and what type of test it was. And, again, like sharing this with your providers. If you had an uncertain variant, your doctor can reach out to the lab to ask for a reanalysis, meaning I want you to look at the data again and see if you find anything that we didn't know last time. At GeneDx, we offer one reanalysis free of charge. We usually recommend you wait a year or two just to kind of like let there be data that builds up. But that is something that you can recommend. Also, if there have been new things that have come up clinically, like for example, when I was diagnosed, my child didn't have seizures, or when my child was diagnosed, he didn't have seizures. Now he does. That's another good reason to reach out, because we interpret the genetic data based on the clinical history. So if you now have seizures, that might bring in a whole nother group of genes that we want to think about and tell you what we found, if that makes sense. So again, really uncertain results are also important, because they can unlock a lot of the same things. There are a lot of clinical trials that are focused even on these uncertain variants, and often you can be included in those, even if it's not a true pathogenic variant yet. So again, lots of things that can be unlocked with that diagnosis, even though it's not definitive. And then with negative, obviously, you're not going to have a gene, you're not going to have a variant, but you still do want to know all of the rest of these questions because, again, if it's been a while, if there's new technology, you might want to have testing with another type of test, or you might want to ask for them to look at the data again to see if they find anything. Um, and even if someone is negative, there still are support groups out there. There are groups that are focused around different diseases like epilepsy, Child Neurology Foundation. Um, and then the only thing that really, like, with people with a negative result don't have access to are kind of like often the research, the clinical trials, and the treatments. Again, there may be some that are studying kind of like these undiagnosed cases, but most often kind of just have to wait and continue checking back. So, in summary, this is just kind of a then and now with regards to exome and genome. Previously, these tests would take forever to come back. The good news is now we can get them back in often 3 to 4 weeks. They used to be pretty expensive. People had to pay a lot out of pocket. But again, good news now, they're very accessible, widely covered by insurance, whether that's commercial or Medicaid. Previously, I think the results were often very confusing. People didn't know how to interpret them. We now give fewer variants of uncertain significance. We give more definitive answers. Um, I think again, sometimes people are like, "Well, there's nothing you're going to do. Like, why would you want to know this?" There's a lot we can do. There are approved therapies for some of these diseases. There's clinical trials. There's dietary, behavioral health therapies. Again, just giving it a name and providing you with a community. And then also previously, some people would say, well, you don't really need the genetic testing because, you can diagnose it based on a CT scan or an MRI. But now we know that exome and genome really will find things that others won't. So it's definitely an important thing and something that payers and professional organizations are paying attention to. So that is it. Um, this is our advocacy inbox at GeneDx. You can reach me there. But yeah, I'm happy to take questions. I feel like that was a mile a minute, but